Good evening. I'd like to welcome everyone to the start of the 2017-2018 Fort Worth Surgical Society season. And we're starting off with a bang. We've got a great speaker and a great talk for you all tonight. If you're a college student, we welcome you. If you're a medical student, we welcome you. If you're a resident, we welcome you. All are welcome. We also want to thank, as we always do, our Moncrief Cancer Institute partners for being great partners over the years, allowing us to have a wonderful facility, wonderful IT support over the years. And Dr. Argenbright has some new thoughts for some new projects this year, so we've got a lot of interesting things planned for you for the year. And our schedule may change. Dawn, who is the IT director, couldn't be here with us tonight. She had a doctor's appointment, so we're going to really institute our remote video conference lectures next month. A little housekeeping, as we do every month. We are offering, through the hard work of Justin Morden and other folks here at the Moncrief, we're offering not just 1 hour Category 1 CME credit, but tonight Dr. Warren and Moncrief are offering a 1 hour of ethics credit. And as always, the system is organized at the Moncrief to obtain your 1 hour credit. Two ways. You can do it either online, or when you leave, before you crank up your car, you can call this cell phone number, and there are flyers out there you can pick up. Before 11 o'clock, you can tell them that you just attended event number 255204. Bingo. This goes into your little account, and you'll have your 1 hour Category 1 CME. So no excuse. If you need the CME, especially ethics, just make a phone call. Bingo, you're done. And again, thanks to the Moncrief staff for setting us up. It makes us easy. We showed this a year before last when we started our video conferencing program. Did not know that Dawn would be here tonight, so we'll discuss this next month. But by and large, if you're attending a video conference, you don't want to broadcast from the bathroom, have your dog in your room. And we had one meeting one time where we had Dr. Don Baer at his house up in Graham, rural Graham. He was video conferencing with us. We kept hearing a and his dog had come in the room. His dog was drinking out of a big water bowl near his computer. So, but that's not appropriate tonight with video conferencing. This is your Fort Worth Surgical Society Executive Committee. Dr. John Freeze has retired from the committee, but he's going to be still quite active and helping us over the year. Dr. Therese Duane, who I believe is the new Chief of Surgery at John Peter Smith, with all the changes that happened over the summer. She's been very active, was at our executive committee meeting, and she's going to be she volunteered to be our consultant, and I say consultant about the MOC program because, as you all know, it's under a lot of, it's in flux. And we discovered this is quite an expensive endeavor and time-consuming thing to get involved with. So she's going to be our advisor on MOC, and she came to the same conclusion that we did. Right now, we're going to watch this and not put a lot of money into it. Dr. Miley and Smith, Ellis Blumendahl Center, Buchanan, and Scott Blumendahl, Suhail Sharif, we thank you for all your commitment and service to the Fort Worth Surgical Society. This is our tentative schedule for the year. Like your operative schedules, as you surgeons still in practice know, as your operative schedules go, these things can change. I was just approached by Dr. Argenbright, who again has some fun surprises for us. So our November schedule may change, but if you can see, next month is rectal cancer, thoracic outlet syndrome, cervical spine trauma. One of our new members, Dr. William Crawford in the back, is going to be talking about foot and ankle surgery. Topic to be announced. We have a interesting rivalry which has started this year when the UNT Health Science Center residency heard that we had a JPS chief resident competition and honorarium and a chief resident lecture. In January, they wanted to have one too. So both programs are having a competition amongst their residents with a prize. Somebody wins a prize, a check, and has the great honor of giving their talk to the Fort Worth Surgical Society. So that's starting this year. In April, we're having a robotic demonstration of robotic thoracic surgery. And this is the first year, I believe, that we will ever have a non-surgeon talk to the Society for the R. Joseph White Lecture in May. Dr. Timothy Miller, who's the chief of anesthesia at Duke University and also the first president of the American ERAS Society. We've talked about ERAS here before, Enhanced Recovery After Surgery. Dr. Miller is a big guru in the worldwide ERAS movement. He's going to talk to us in May about the importance of being involved with the ERAS movement. So this is your tentative schedule for 2017, 2018. We're already booking into the fall of 2018. If you have no speaker or you have something you're dying to talk about, let me know, as always. A few little things that are coming up in Fort Worth just this week. If you want another ethics lecture, if you can't get enough ethics, Steve Davis is giving a talk at the Rob Relich Auditorium at Harris on Thursday, the ethics of non-invasive ventilation. I haven't a clue what that means, but Steve's a good speaker and usually gets a good talk organized. So free lunch Thursday at Harris, 12 to 1, ethics of non-invasive ventilation. For you golfers, the Tarrant County Medical Society fall golf tournament's going to be at Ridgely Country Club Tuesday, September 26th. As we did last year, the Fort Worth Surgical Society is co-sponsoring a sporting clay shoot, a fundraising sporting clay shoot for both societies. This is going to be at Alpine. Beaumont Ranch was a long way away, but the Dental Society was able to get the date at Alpine, September 30th. This is a Saturday on a non-home TCU football game weekend. So it's $100. We're going to get about $10 per shooter to split with the societies. And so this is the Dental Society, Surgical Society sporting clay shoot. There's some flyers out front you can pick up if you want to get involved, and just let me know. The Texas Surgical Society, the fall meeting is, I'm sure you've all been bombarded, who are members, bombarded with emails. The fall meeting is going to be in San Antonio, October 6th through 8th. I believe it says here this is going to be at, it doesn't say.
La Cantera,
Austin.
San Antonio.
Okay, but the hotel.
La Cantera.
There we go. Okay. Anyway, enough of that. Our speaker this evening gave a similar talk you may have heard at the fall meeting of the Texas Surgical Society in Dallas last fall. It was very well received, and the president at that time, Dr. Lee Blumenthal, a member of our society, said we had to have Dr. Warren come back and speak to our membership this year. She was so good. Dr. Warren was born in Louisiana. She attended TCU, got her BS in psychology in 1993, went on to get an MS in mental health counseling in South Florida at Nova Southeastern University in 1995. Dr. Warren then came back to Denton at UNT. She got her PhD in clinical health psychology in 2003. Dr. Warren is the author of 60 articles on mental health in medical specialists. She has given 20 presentations. She's authored 6 book chapters, and Dr. Warren is married to an orthopedic trauma surgeon at Baylor in Dallas. She's married, has 2 children, and she says her stress relievers, when she gets stressed, her stress relievers are her wonderful husband, 2 dogs, and a ranch down near Corsicana. Am I right about all that?
That's right, in Blooming Grove.
In Blooming Grove. Sounds very zen.
Fancy,
Sounds very zen in Corsicana. Anyway, I won't go through the rest of her CV. Dr. Warren is very active over at Baylor Medical Center. When I thought about this talk and thought about what to say before she began, I thought this was something that would have relevance for medical students, for residents, but as Dr. Warren will tell you, she counsels a lot of faculty, a lot of other health professionals. They're so busy over there that she told me to announce that they need 6 to 8 full-time psychology jobs over at Bumsey. So if anybody that is well trained and needs a job, they'd like to have 6 to 8 more people in their department. As you all know, this is a very big issue. It's in every specialist journal and has been the last several years. I just came back from a medical meeting in Boston and a reunion at the hospital I trained in Boston, and one talk in the morning, Saturday morning, was the it wasn't new, but the young program director, and the residency has changed quite a bit. And the last two slides of his presentation were about their program to deal with resident stress and burnout. Their program included faculty mentors, brother-sister or big-sister, big brother programs. So they would match an intern with a fourth or fifth year that have monthly or every other month activities with the department, like softball games and so forth. They have hired about 10 nurse practitioners and PAs to take a lot of the calls, especially at night and during events during the day. So that tells you how seriously they take the issue. Despite that, they still have a lot of problems, residents that drop out. It's a big issue across the country. Without further ado, I'd like to introduce Dr. Anne Marie Warren from Baylor Medical Center, who will talk to us tonight on the ethics of caring, suggestions for surgeons to protect against post-traumatic stress, compassion fatigue, and burnout. Anne Marie, thank you for being here with us.
Thank you. Thank you so much. Can you guys hear me okay on the microphone? Is it good? Okay. Thank you for inviting me to the Fort Worth Surgical Society meeting tonight. It is obviously an honor to come here, and hopefully this talk will be interesting. I always tell people if I talk the whole time and no one else talks, that's really boring. So feel free to jump in with your thoughts as we go. This is my home. I've been at BUMC for 18 years. We're now supposed to call it Baylor Scott and White something University. Everything's Baylor Scott and White now, but I still always call it BUMC. They're actually taking our flame down and putting up the new Baylor Scott and White logo. But that being said, to me, it's BUMC. I list all these job titles that I have not to be obnoxious, but to share with you that I think all of you can relate, that really for most of us, we're in multiple roles in our settings, and that can lead to burnout. One of the things that I do as well, I am the co-chair for Health Texas of our Physician Resource Committee, so I'm very involved with that, but I do a lot of clinical work and research work as well. Despite all those job titles, I have nothing to disclose, so maybe I'm not doing this right with all those job titles. So what are the objectives? To distinguish the difference among burnout, PTSD, and compassion fatigue. I think you're probably hearing a lot of those terms being kind of passed around, and they're used interchangeably, so I want to make sure we're defining it. I want to describe the consequences of these different syndromes, and I want to talk about strategies, both professional, personal, and organizational strategies to kind of help cope with that. All right. I'm going to start with the Miracle on the Hudson. Is everyone familiar with the story of the Miracle on the Hudson? Kind of see some head nods. You may have seen the movie. I did not see the movie, but just for a reminder, in 2014, Captain Sully was piloting this U.S. Airways plane, and as it was coming in, it hit a group of birds. If I'm not mistaken, they were Canadian geese, but don't quote me on that. I'm not sure if they were Canadian geese. But either way, the plane hits a bunch of birds, and what happens? He has this miracle landing on the Hudson. So no one died, no one was injured. It was this very courageous thing that happened. All the passengers survived. But I guess my question to you is, for a seasoned pilot like Captain Sully, that was probably, would you all agree, that was a stressful event when he had to land that plane and save all those lives, right? So my next question is, do you think that U.S. Airways, after that very stressful, unexpected, unintended event, although successful, everybody lived, do you think that U.S. Airways asked Captain Sully and the rest of the team to go back and take the next flight that they had scheduled out? No. Do you know how long they asked the team to not go back and fly? Let's take a guess.
6 months.
Yeah, I mean, 6 months. You actually heard it. And if you read the JAMA article that they did an opinion piece on this, there was like a 6-month period at least where they didn't have them. And you know what else they did afterwards? They had a whole team of mental health people and others to help them process the event. And why? Because that's an objectively very stressful thing. Now, as surgeons, you know how many lectures have you heard about what we learned from the airline industry, right? You learn about process, you learn about that kind of thing. But if you have a case and the outcome is unexpected or unintended, do you get to not do the next case? No. So I would argue the question about this is the ethical question. If you're the patient on case number 2 at 9 o'clock, and case number 1 had an unintended outcome of, let's say, even a consequence or even a patient death, do you think that the patient that you're going to see on case number 2 should know that something dramatic happened before?
No.
I mean, it's a really interesting question, right? Because I would argue that the emotional consequences of something you weren't expecting, it's not too much different than Captain Sully. And the point I make about this, JAMA did a great opinion piece on it, because the point is, if we're going to give Captain Sully and his team the opportunity to kind of heal from that event, why aren't we doing that for surgeons and physicians who have complications? Because I don't know how it is for everyone, but I know that for a lot of my trauma surgeon colleagues and other surgeon colleagues, something unexpected happens, they go right back into the next case. So it's a question I want you to kind of think about as we're talking about how we're addressing this for surgeons, because you're like the captain of the team, and we have to make sure everybody's doing okay. So just something to keep in mind as we go forward. Okay.
Dr. Warren?
Yes, sir.
Comment on that.
Yes.
Not only was it successful, but he was immediately questioned about his decision.
Yes,
Did he
sir.
make the right decision? Even though the outcome was good,
Yes.
he had experts arguing he should have flown it to another airport,
Yes.
which was not the right decision.
Right.
But he went through a serious mental trauma of
Yes.
debating his own decision.
Exactly. But given the time and the resources and support to help him process that, so when he was ready to fly again, he would be ready. And yes, sir. But great point.
There's quite a bit of difference between an airline pilot and a surgeon. I'm sure that he was still receiving some salary during the time he was involved.
Yeah.
If you quit doing an operation for 6 months, you would go broke and have to close your office.
Exactly.
So there's a little bit of difference in the economics of that.
So that is an excellent point, and I would just say that I think it's kind of more the spirit of it, because at least what I observed in working in the medical setting is that if something difficult happens, there does not seem to be a real standardized approach to making sure everybody's okay. Because you're right, that's unrealistic for anyone to do that. But I think it's just that, providing the resource if someone needs it. And someone may not need it, but just being available for that resource. But excellent point. Yes, sir.
I was always told, metaphorically, if you've thrown off the horse, you get back on it and ride. So I think how you respond to that, and it should be, is the demeanor of the individual.
Yes.
Some can stand it, some can't. And then
Yes. You are, again, correct. I would say simply just knowing that you're right, some people need to get back into it. We could have a whole talk about avoidance and PTSD and how we don't want to avoid things that make us anxious. But I think the concern is that, at least in the healthcare setting, it appears there's not a lot of, if someone needs that, let's say someone isn't able to get back on the horse right away, what are we doing to make sure that they're okay? So, yes.
When I was in high school during the summers, I had the opportunity of being an orderly in a major medical center in Minneapolis. I was in the operating room all the time and helping as an orderly would. But there were two situations that I can remember distinctively that would fit exactly into what you're talking about. One was during an era of hoping to drop ether for tonsillectomies of children. And the other was a surgeon doing what should have been a standard operating room situation, a hernia operation on a young man. I don't know how old the young man was, young adult or an older adolescent or whatnot. For whatever reasons, both of those two people died. It wasn't necessarily on the same day. But I can remember distinctively, clear cut, wondering at that time, how in the world, because how it would affect those two surgeons respectively. Because you're not normally used to having those kinds of patients die. They just don't, but they did. So I don't know how in the world those folks tolerated that, or how they got through it without having some very severe mental problems.
And a great example, and I think you're making the point that you can do everything right and something unexpected still happens, right? So, yes, sir.
There's a couple of apodictic postulates here. One is you have an ethical duty to be competent.
Yeah.
It's embedded in the 9 principles in the Code of Medical Ethics. And the second thing is you're not always very good at assessing your own competence. And the people who are at risk of assessing their own competence are the ones in the bottom quartile, which are perhaps at more risk for these kind of events. Both of those things are pretty well documented.
Right. And I think that's, again, a good point. It's like sometimes we don't even kind of know how we're reacting to something. But just, I think part of it is, one of the reasons I think there is so much focus now on how we're reacting emotionally to difficult situations is because we need to be able to talk about it and figure out, are you handling it well? So it's just something to kind of give us some framework for the rest of the talk. And I think, at least the colleagues I work with, when we start talking about burnout, everyone starts rolling their eyes and saying, I'm burned out of hearing about burnout. And I don't know if anyone else feels that way, but I think that's true. But why does it matter? Well, some of the stats from JAMA 2016, 40% of surgeons experience burnout, 30% experience depression. But this is interesting. When you compare the mental health of the population of the United States as a whole, surgeons actually have 28% have a mental quality of life score greater than half of the standard deviation below the population norm. So it's actually surprising that quality of life is being affected in the surgeon population compared to the general population. No surprise to anyone probably, burnout, compassion fatigue, post-traumatic stress is associated with anxiety, sleep disturbance and fatigue, broken relationships, marital dysfunction, divorce, early retirement. So we see some correlations in the literature with that. And it's been implicated in medical errors. It affects patient satisfaction. I don't know in your shops, but certainly at Baylor, we talk about patient satisfaction ad nauseum, and the research actually shows that burnout does affect that. And this stat to me is really interesting. 50% of physicians and 70% of the general public believe that surgeons who are overworked, stressed, and sleep deprived contribute to medical errors. That is not saying that that is what is happening, but the perception of the general public is that that's what's happening. So if your patient perceives you as burned out, they're gonna see you that may affect medical errors. So I think perception is really important, and there is that perception when you look at the literature. Again, probably no surprise, problematic alcohol use is defined by the audit, and that's just a measuring tool for risky alcohol use. Surgeons actually had a higher rate of risky alcohol use compared to 9% of the U.S. population in the study of 7,900 surgeons. Interestingly, female surgeons had more trouble with alcohol use than male surgeons. I don't know why that is. That was just interesting. And among the 722 physicians who said they'd had a major medical error in the past 3 months, 77% of them scored within the range of having alcohol problems. So again, we see this connection between burnout, stress, overuse of alcohol, and problems down the road. Now we're getting to a topic that when I did this at Texas Surgical Society, we had a lot of conversation about this. Suicide is a problem in the medical profession, and it's certainly the case among surgeons as well. 1 in 16 surgeons reported suicidal thoughts in the last year in the big American College of Surgeons study. Risk factors for suicidal thoughts include depression, surgeon burnout, having made a recent major medical error, and those are all independent risk factors for suicidal thoughts. But again, perception is reality, right? The perception, not making a medical mistake, but the perception of having made a major medical mistake in the previous 3 months was associated with a 3-fold increased risk for suicidal ideation. That's really powerful. I mean, it's really powerful. 16.2% of surgeons who reported a recent major error reported suicidal ideation, compared with 5.4% of those who did not report an error. So we know that, we'll talk a little bit more about suicide in a minute, but we know again, these emotional things are definitely a factor, and they put us all at risk. No surprise, when people had suicidal thoughts, they had more distress, depression, and they had all 3 aspects of burnout, which we'll talk about later, which is emotional exhaustion, depersonalization, and low personal accomplishment. Okay, I know these slides are kind of heavy, but of the 501 surgeons who reported past year suicidal thoughts, only 26% sought help from a psychiatrist or psychologist, and this rate of 26% of surgeons seeking help is substantially lower than the general population of 44% of individuals in the general population with suicidal thoughts. I think we were speaking earlier and when we were eating about the idea of there's this need to feel like you have to soldier on no matter what's happening, but I think that that's really concerning that the general population is more likely to seek help than surgeons. And then more than 1/3 of surgeons overall, and more than 60% of those with suicidal ideation indicated that they would be reluctant to seek professional help for mental health problems out of concern that it might affect their license to practice. Any thoughts on that? I'm throwing that out there, just thoughts. Is that surprising to the group? Is that not surprising?
In your first paragraph, it says low personal accomplishment. Is that actual accomplishment or
Perception, because it's kind of one of the domains of burnout is that you're not accomplishing a lot. So, but I find these slides to be these in particular to be kind of really powerful when we think about the mental health impact, and most importantly that people are reluctant to seek help. And I know that's concerns about license and things like that. But okay. So then people tell me all the time, this will not happen to me. I am immune to these issues. But I use this quote because I think this is very powerful. The expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. The point is, we can't go into this profession, we can't be around people who are suffering and not somehow be impacted by that. So, all right. So we're going to talk about the definitions. We're going to start with PTSD. PTSD is a lot of my clinical work with our level 1 trauma patients, so I deal quite a bit with PTSD clinically. I won't spend a whole lot of time on the definitions. The thing to know, you guys are familiar with this. This is kind of for mental health professionals. This is kind of the Bible, the DSM-5. This is how we make all these diagnoses. It's the size of a phone book. I don't think it should be that big, but I don't get to write it because I think a lot of them overlap, but that's my personal opinion, never mind. Okay, let's talk about the criteria. Why is this important? PTSD in 2013 changed the exposure criteria. The key about PTSD is that you have to be exposed to something traumatic. If you don't get exposed to something traumatic, you can't have PTSD. But why did I highlight these yellow ones for this audience? So exposure to actual threat, death, serious injury, or sexual violence by direct experience, witnessing person, repeated or extreme exposure to aversive details of traumatic events. Who in this room has been affected by that?
That's an average surgeon's day.
Right. So by the change in the definition, before 2013, we did not have this as defined in the exposure criteria. So this is why some of the definitions have changed, but certainly you're at risk for that, I think, working in this field. Criterion B is the intrusion. And basically intrusion is when people are having distressing memories of the trauma, distressing dreams, flashbacks, that kind of thing. Again, you guys know the definition. I won't spend a whole lot of time on this. Avoidance, I will tell you this, avoidance is one of the most clear things if someone's going to have PTSD or not. If you have a traumatic experience, we actually, treatment-wise, the treatments that work is where we don't let people avoid the things they're fearful of. So the 2 gold standards for PTSD treatment are all involved with exposure therapy. So let's say, real quick example, let's say that I leave and go to the parking lot and I get shot in the arm by someone robbing me. Then as a PTSD person, if I develop PTSD symptoms down the road, I would probably be not likely to go to parking lots. I wouldn't come to this parking lot. I wouldn't go to any parking lot. So the treatment for that would be getting me in as many parking lots as possible so I get over that fear. It's prolonged exposure therapy, and it actually works 85% of the time. So the point of that is when people avoiding traumatic memories maintains the PTSD. So just know that for your patients or for people you know, we don't want to avoid things that we're fearful of. Okay. Also, the new thing that happened, the negative alterations in cognition and mood, that's what changed as well in the 2013 definition, meaning that because PTSD and depression are so comorbid, we realize that when people have PTSD, they don't remember the trauma, they look at the world as a negative place, the world's not safe, and they have cognitive distortions about the trauma. They have persistent negative emotional state, loss of interest in activities, and you start to look at this and you see this is really very similar to the diagnosis of depression. But again, for some people, and we'll talk about how it applies to surgeons in a minute, this may look, kind of familiar. And finally, arousal. It's interesting, one of the studies we did looking at indirect PTSD in surgeons that we published in Journal of Trauma and Acute Care Surgery, the PTSD symptom that was highest in the surgeon population was irritability. So that just popped out in the PTSD symptom list. But basically, arousal is what we see, the things we see in PTSD, irritable behavior, hypervigilance, problems with concentration. These are things we start to see when someone has a PTSD diagnosis. And finally, no surprise again to you because you know the definition, you can't have PTSD unless you have the symptoms for at least 30 days. Just know I gently correct my trauma surgeon colleagues at Bumsey when they say someone has PTSD and they've been shot and it's been 2 days later and the resident writes PTSD, and I have to say, no, it's acute stress disorder, it's not PTSD. But just know that the symptoms have to be going on for at least a month and it has to interfere with your life function. So I just want to give a quick overview of what PTSD is. By the way, what do you think the general population is? How many people in the United States at any given time have PTSD? Do you know? So if you gave a number.
A million.
A million? What percent though? 60%. 60%. Okay, you went super high, that Americans are super traumatized. Yeah. Well, I'll come back to that. 85 to 90% of Americans will have some trauma event in their entire lifetime. But of that, and this is the critical piece, only 7.8% will develop PTSD. I want you to remember that population number because we're going to come back to that as it relates to surgeons. Okay, compassion fatigue. So we're going to do the definitions first. And what's really kind of scary is if I Google burned out physician pictures and I Google that and get images, thousands of images show up like this. Everybody's seen these pictures, but there's a lot of distressed looking physicians on Google images. Compassion fatigue. Compassion fatigue is, if you hear these terms when you hear these topics, secondary traumatization, vicarious traumatization, secondary victimization, secondary traumatic stress, these are all interchangeable terms, okay? But they all kind of relate to the same thing, which I'll talk about what it is. It's kind of like PTSD, and now that the PTSD definition has changed, it really is more like PTSD. But basically, compassion fatigue or compassion trauma is when you are in a caring profession or a helping profession, and the indirect impact of being around others' experience affects you directly. And mainly it's because you start to over-identify with the trauma that the individual experienced. And you start to have the same symptoms that the patient experiences. Dr. Charles Stigley, who helped us define this, he calls it the natural consequent behaviors and emotions resulting from knowledge about a traumatizing event experienced by another. So it's the stress of wanting to help someone. Now, why is this important? Because why are surgeons at risk in particular? Hopefully everyone agrees with this statement. Empathy is a major component required to help those with a difficult medical event. Would everyone agree that you need to have empathy to do what you do? Right? So you have that. So we all have empathy. We all theoretically go into helping professions because we have empathy. And then many providers also themselves have had a trauma. Remember we said 90% of Americans will have a traumatic event in their life at some time. So the unresolved trauma combined with the empathy of helping others, and the demands you have of taking care of multiple patients, that all kinds of comes to this perfect storm that creates this compassion fatigue. And we looked at this secondary traumatic stress or compassion fatigue. It's been studied in a lot of other disciplines. So it's been looked at in nurses, oncology nurses, hospice nurses, ED nurses, ED physicians. But it's also been looked at outside of the medical care teams. It's been looked at child welfare workers, mental health professionals treating sex offenders, social workers after 9/11. But I found this statistic really fascinating. There was more studies of indirect PTSD or secondary traumatic stress in attorneys than physicians, which at the time, before we did our work on this, I was really blown away by that, because not that attorneys don't have empathy, because they do, but I just think it's interesting that had been studied very much in the attorney population. So we did a study, I won't bore you with all the details, but we published this again in 2013, And what we looked at is we looked at about 120 surgeons, and we wanted to see what their indirect PTSD rates were. Again, this is right before the change of DSM to add the exposure criteria I talked about earlier, so now we would call this just PTSD. But we looked at years of practice, exposure to trauma patients, age, gender, practice setting. Our hypothesis was that surgeons who were more exposed to trauma patients would likely have more trauma reaction. But that's not what we found. First, we found 21.9% of the sample, so a big chunk of the sample met criteria, diagnostic criteria for PTSD. Not only that, almost 65% had some symptoms. But the only thing we found, because we also looked at this concept called resilience or hardiness, the only thing we found that was associated with that group that had this 21.9% and the 64.5%, if they had low resilience, so if they were not resilient people, they tended to have higher rates of PTSD. And it wasn't the exposure to practice, et cetera, which was surprising. Age didn't make a difference, gender didn't make a difference, et cetera. And there was a more recent study done in 2014, also in Journal of Trauma and Acute Care Surgery. And this was a survey sent to like maybe 1,200 surgeons with AAST and East. And what they did is, again, they found, whoops, sorry guys, they found similar rates. So ours was 21.9, well, ours was 20.9%, theirs was 15. 15% met diagnostic criteria. But this again was fascinating to me. The risk factors for developing PTSD in the trauma surgeon: male, operating greater than 15 cases a month, having more than 7 call days a month, minimal relaxation time, which they defined as less than 4 hours. That was minimal. But again, no association with age, years of practice, or those surgeons who were past military. That didn't make a difference. But these factors were predictive of developing PTSD. So we're learning more and more about the factors that make people at risk for developing PTSD in the surgeon population. And it's a little different. Now we're going to switch to burnout because, again, we're defining things. In burnout, this is from the Mayo survey. Ted Shanafeld at Burnout is kind of, at Mayo, excuse me, is kind of the burnout expert right now in the United States. But this was a large survey of physicians, and I think this study really was very powerful. 54% of doctors in general, not just surgeons, 54% say they're burned out. 88% say they're moderately to severely stressed. But this one really was kind of sad to me. 59% of doctors would not recommend a career in medicine to their children. Is that surprising to you?
No.
No. Why do you think that's not surprising?
Because I'm just basing it on mine. They saw what I did, and I didn't even have to tell them about it. Recommending and not do it.
Right. Thank you for sharing that. I think that speaks to the burnout crisis that's happening. And I'll tell you, as we define burnout, it was first described in the 1970s by a psychiatrist, and they were looking at overworked mental health care clinic volunteers. But the definition that this gentleman gave, which I'm not going to try to pronounce the name, Freudenberger, I'll go with that, progressive loss of idealism, energy, and purpose experienced by people in the helping professions as a result of the condition of their work. So the key here is the condition of their work. And if you think about the difference between PTSD and compassion fatigue and burnout, and this is important, when people have PTSD or compassion fatigue, they still have something really critical. Usually they still have empathy. They still care. When people reach a burnout stage, these are your colleagues that just say, I just don't care anymore. And that leads us to a whole different level of things. But that's why burnout, it's important for you to understand the difference, because this is problematic. It's a form of mental distress manifest in normal individuals who experience a decline in performance resulting from negative attitudes and behaviors, and it's characterized again by this emotional exhaustion, cynicism, detached from the job, sense of ineffectiveness, and lack of personal accomplishment. I put this little cartoon up here. It says, and if you can't read it, it says, we're doing a heart transplant and you brought me a kidney. Well, we'll just have to make do. That is the perfect classic example of burnout. You just don't care anymore. So I try to use humor when I talk, so because it makes it more interesting. So again, fatigue, irritability,
If
physical
he
complaint.
reacts in anger, then he's going to go into anger management.
That's right, yes. Yes, exactly. So again, we talk about the burnout stuff. Now, Medscape every year does a really nice lifestyle thing that they survey physicians from all over the country. How many people have seen the Medscape lifestyle stuff that they put out? It's really interesting. This year in 2017, they looked at burnout by region, and I don't know, I thought there might be more regional differences, but if you can see the slide, there's really not a big variation of regional differences. So I don't know why. I guess I thought that maybe some areas of the country people would be more burned out, but according to the data, that is not the case. It's about the same. But before I give you this slide, which physicians would you guess by specialty are the most burned out? And if you looked at the slide, don't answer.
General surgeons.
General surgeons. Does anyone want to give another guess? Good guess. What else? Anyone else?
Gastroenterologists are probably the happiest.
Well, you're going to be, I was surprised on who's the happiest because we're going to get to that. The most burned out ones are emergency medicine, OBGYN. Now, let's see, where's general surgery? It's kind of down here, kind of in the middle. Mental health, it says that we're the least burned out. I'm not sure if I bought that, but that's actually, the 2016 was the same. So you kind of see where the high stressors go. Next slide, the severity. Now, interesting, urology had the most severe burnout of the ones that said they were burned out, oncology, cardiology, etc. Causes of burnout. The top ones, too many bureaucratic tasks, spending too many hours at work, feeling like a cog in the wheel. The EHR, no surprise. We just implemented Epic in our outpatient at not Bumsey, at Health Texas, and it's caused a lot of stress. Income not high enough, difficult patients. Okay, so work-related stuff, right? Remember, the definition of burnout is the work environment contributes to the burnout. Okay, don't look at that slide. Who's the happiest? What physician group is the happiest?
Retired.
Retired?
Pediatricians.
Pediatricians, retired, what else?
They're the least.
The least? Obstetricians. Okay, I was surprised by this. Urology. Apparently your urology colleagues are the happiest people. I don't understand. Followed by ophthalmology and dermatology. Any takers on why that was the case?
Yeah.
What do you think?
No, I think that's correct.
You think so?
Pediatricians traditionally are dissatisfied with their practice the most.
Pediatricians
They're
are.
way up there.
Yeah. And so when we talk about who's not happy, where do pediatricians fall on this list? The pediatricians were kind of a little happy. They were less happy than the orthopods. But again, the least happy, rheumatology, nephrology, internal medicine, and where's surgery again, is kind of here in the middle. So, interesting. And then risk factors for burnout: excessive workload, lack of control and autonomy, EMR quality measures, meaningful use. If you can see this slide, everyone is here to save you, but unfortunately you're not in the computer. Right, so technology can be helpful, but it's also related to a lot of burnout. So risk factors for burnout in the work environment: lack of advancement, not so much an issue I think for the surgeon group, but poor social support within the workplace. How much you're getting supported by your colleagues, that's a risk factor. Perceived inequality, and that can be not just salary but professional respect. If you don't perceive you're getting the professional respect that you should. And this is a big one I think for surgeons: lack of work-life balance. Okay, so these again put you at risk for burnout. Personal factors, interesting, younger age. So people who are practicing in the first 1 to 5 years are actually more at risk for burnout than people who are practicing longer. And I've seen this statistic repeated. That actually surprised me, only because I would feel that as people practice longer, they kind of learn the skill set to manage things a little bit better. But the data keeps showing that first 1 to 5 years is the most at risk. Lack of social support. So if we don't have social support, we're at risk. It's interesting, the things that make us successful at our job. I was talking to an internist this morning who had reached out to our committee because they were having a lot of burnout issues, and we were discussing, and it's like the things that make you successful as a surgeon are the things that put you at risk for burning out. So higher education, right? overachieving? I mean, if I had you raise your hands, I won't, but how many people would say they're overachievers, perfectionists, conscientious? I mean, how many people would agree to that? You don't get to be successful in this field unless you're good at these things. But unfortunately, that puts you at risk for burning out. And lack of personal limits is another one too. You got to recognize what your limits are. Very hard to do. So how do we know if we're having PTSD or compassion fatigue or burnout? And I think this kind of helps you think through it. So burnout is the stress between the clinician and the environment. So it's not your direct interaction with the patient, it's the environment and the setting in which you're in that puts you at risk. Whereas post-traumatic stress and compassion fatigue involves the relationship between the clinician and the patient. Meaning, you have a patient that comes into your clinic that has this horrible, tragic story, and you start to over-identify with that. Burnout usually develops gradually, and PTSD is usually a more rapid onset and is associated with a specific event. So again, we see people who are burned out, who are dealing with these symptoms, they're kind of limping along, and they just kind of get done. The PTSD compassion fatigue is a little more acute when we look at that. Okay, so what do we do about all this? Personal strategies, prevention, education are critical. That's why it's so wonderful that you guys have this topic tonight, because you do have to kind of learn about how we prevent this. Adequate sleep is huge, and I know this is a very controversial issue in terms of how people get sleep. How can you get adequate sleep with the work you do? But it's critically important. We do some work with our trauma center, with our local police departments, with Garland Police Department, Dallas Police Department, and one of the things we're working with, yes sir.
Well, I interrupt you, but
yes.
Before we get into the strategies, your action plan of your facility, what is your problem at Bumsey? How big is your problem? Who is it in? Is it residents and faculty? How big a problem is it at Bumsey?
It's a great question. So I think it is, when we look at where we're focused on strategies, we're looking within Health Texas, which is of course our physician group that supports Bumsey and other hospitals, and we look at Bumsey as a whole. I would say the numbers that we gave on the other statistics would probably be about where our numbers would be if we polled ours. In fact, I will say this, we looked at all of our Health Texas physicians, and we did the Mayo Physician Wellness Index, which is a really good measure of physician distress, and about 25% of individuals, Health Texas physicians, fell in that very distressed range. They also were not resilient. But yes, so I mean, but if you think a quarter is a big number. I mean, if you said a quarter of physicians or surgeons had some kind of disease, we would do something about it. So I think that's a big, powerful thing, that we have a lot of people that are affected. Does that kind of answer your question?
Oh yeah. I mean, how many physicians? 2,000, 5,000 physicians?
In Health Texas alone, we have close to 2,000 physicians and APPs, maybe more like 1,500, but yeah. And then there are physician groups outside of Health Texas, but I think it's a decent problem for sure. And then of course with the residents and things like that, we're required for GME to provide support for them as well. But what we're trying to do is kind of change the culture at Baylor where we can talk about these things, because no one likes to talk about this. Sometimes people are like, yeah, I don't want to go hear Dr. Warren talk again about this, but it's important. So, but the sleep thing I was mentioning before, this is huge. I know that part of the role of what you do is you don't get a lot of sleep. We're doing some work. I bring up the police because we're doing some work as the trauma center, working with the Garland Police and Dallas Police, because one of the things we're seeing is that when people do not get enough sleep, it just creates so many, a cascade of mental health effects that are really hard to overcome and make people more at risk for some of these things. So we're really working on some kind of cool strategies to help with sleep, because sleep is important if you can get it. Regular exercise, obviously we know this, and I'm sure you guys are familiar with the studies. The newer studies coming out are saying that for mild to moderate depression, if people will exercise, that is equally as effective as an antidepressant. So as a psychologist, for my patients that can't exercise, I always start with exercise. Go exercise, because we know that affects their mood for sure if it's mild to moderate. Meditation, relaxation. And by the way, if you start doing some meditation, you don't have to meditate for 2 hours a day. No one has time to do that. There's some great apps you can get on the phone that help you do quick meditation. You know, even taking just a few minutes to do some deep breathing and slow breathing, that can really help your heart rate and things like that. So just learning some strategies like that are really good. Healthy nutrition. I mean, everybody's busy. When we're busy, we don't eat healthy, so that's a very important strategy. Enjoying non-work related activities. We were talking at dinner, we were chatting about the retirement issue. You were sharing, you know, I think what you said was very important, where you said one of the challenges is if people don't have outside activities they enjoy outside of their practice, then when they do retire, that's a huge kind of emotional struggle. And I think I've seen that even in my own family with my father, who's a retired physician. So I think learning to enjoy the non-work related activities is very important to reduce burnout. Work-life balance. This one's a little more touchy-feely, but I think it's important. Certainly we see this in our ICU teams. In the intensive care unit, I work a lot with the staff and the nurses, and one of the things that's challenging is when they have a patient death in the ICU, there's not a lot of time to kind of process that and move, you know, you just kind of have to move on to the next. So giving people time to grieve patients when they've been lost, learning coping skills, spiritual need, and humor. And this is humor, so psychiatric help. So we know that also, in addition to, and I didn't mean to gloss over that, spiritual needs and humor. And by the way, spirituality, of course, does not mean you have to be a certain religion or go to church every Sunday. That's not what that means. Spiritual needs means it can look like the religious practice you have, but it's just saying that you have some kind of meaning and something higher than you. We know the research all supports that's critically important. And humor is very important. So humor is very, very important. So then I was going to go to this slide. Psychiatric help. For those of you old enough, including myself, to remember Peanuts, this is Lucy. Okay, so professional strategies, peer consultation and discussion. That's kind of what you're doing here. You know, when you have these meetings, gives you guys a chance to kind of have that peer consultation, setting boundaries and personal limits, learning when to say no. I think that's really hard for all of us in this field to say no. You know, I can't take on one more thing. And I showed you that slide in the beginning with my laundry list of things that I'm not saying no to, and I need to say no. So I need to practice what I preach. Identifying potential responses to difficult scenarios with patients. Again, I think practicing how do we relate when there is some difficult situation. In Dallas, of course, you all are very well aware we had the police shootings 2 Julys ago. That was a scenario that certainly the trauma team had practiced for and they were ready for, but still when that happens, that took a toll on everyone. It took a toll on the surgeons, the residents, took a toll on the scribes who were there that night, took a toll on the dispatchers at the hospital. And so you can, but if we hadn't practiced at least the basics of how do we handle a mass casualty event, it makes it harder. So we want to definitely practice things that could be stressful. And again, as you're doing tonight, meeting regularly with professional groups, that's helpful. Organizational strategies, that's what we're trying to do at Baylor. Scott and White is not keeping compassion, fatigue, and burnout a secret. We need to be talking about these things, because I find one of the things we do at Baylor in Health Texas is we have a very strong peer support group, because at the end of the day, as we said in the first couple slides, people are not likely to always come and talk to a psychologist, but you might be more likely to talk to one of your peers. So having that peer support, having someone you can talk to that truly understands, because even though I'm married to a surgeon and I grew up in a home with a physician father, I don't know what it's like to go in the operating room, open someone up, and do what you do in there. So having the ability to talk to your colleagues about something is critically important. So we really want to have that as a cultural thing we do, respecting each other, creating a team, and recognizing that something does not have to be a death, like the ultimate bad outcome, to be traumatizing. We're all affected by different things, and different things traumatize us in different ways. So something that may be very traumatizing to me may not be traumatizing to someone else. I'll go back to the Dallas shootings real quick. After the shootings happened, they started sending all the nurses and physicians and residents, they said, well, you need to go see the psychologist and what have you. But it was interesting, because some of the people that came by to see me, it wasn't the shooting that night that was really affecting them. It was something that had happened the week before, that for whatever reason, as traumatic as the shootings were, it wasn't the most traumatic thing for them personally. So I think we have to recognize it's very individual. So at Bum Sleep, one of the strategies we have, if you don't know this gentleman, how many people know this gentleman? Yes. Dr. Michael Foreman, he's our head of trauma surgery. He's been there since the 80s. Pet therapy. Now, I'm going to do a quick plug for pet therapy. I have 2 dogs myself, but that's not what I'm giving the plug. We started doing pet therapy at Baylor a while ago for the patients. So we bring them on the trauma unit. We even bring them in the ICU to some of the very, very distressed family members while their loved one was intubated and sedated. But what we found is, do you know who the pets help the most? The surgeons, the nurses, the staff. So we do on trauma, we do 2 days a week where we bring dogs in. This is Lily, by the way. But you can see it really is an important thing. So this is a big part of what we're doing at Baylor. But you just have to find something that works for your team. And I love this slide, and if you can't see it, it's a psychiatrist or psychologist talking to a patient. It says, go home and let your dog lick your face. Dog saliva is the most effective antidepressant you can get without a prescription. I love that. I think that's really cute. Okay, finally, as we're wrapping up, we want to talk about compassion satisfaction. So we've talked a lot tonight about how the work we do affects us in a negative way, but I think this is why everyone in here does what they do, because it's the idea of compassion satisfaction. This is the pleasure we get out of the work we do by helping others. And it likely, for those of us that experience compassion satisfaction, it counterbalances the stress that we get from doing the hard stuff and speaks to the resilience of the human spirit. There's also a concept called vicarious post-traumatic growth. So when I talk with patients a lot, we talk about after a trauma, because I see a lot of highly traumatized people, we talk about this concept about post-traumatic growth, meaning when you have something very difficult happen in your life, and you can think of anything in your life that's been difficult and try to apply it to yourself. At the moment, it probably seemed like a horrible thing and you wish it hadn't happened. But if you go fast forward 6 months, a year later, what normally happens? You start to see that because of that very negative thing, something really positive came out of it. Your relationships with others got deeper, you found new meaning in life. And what we find is there's also the concept of vicarious post-traumatic growth. That when we work with patients who go through something very traumatic, and we see them survive and thrive, you see them a year later, they come back and see you for a clinic visit, and this is someone who you thought, my gosh, they may not make it, their life is going to be altered forever, and they come back and they're doing better. That concept of vicarious post-traumatic growth also enriches what you do too. So I think that's the heart of what we do. And finally, I'll leave you with this quote, self-care is an ethical imperative. We have an obligation to our patients as well as to ourselves, our colleagues, and our loved ones not to be damaged by the work that we do. So thank you for your attention tonight, and it was a pleasure to speak to you. Any questions?
Questions?
Yes. Yes.
Oh, the problem I see with the average physician is that their choice of therapy is purely voluntary, whereas a hired person like Sully or a policeman that shoots somebody, they're forced into psychological evaluation and counseling until they're allowed to be returned or be dismissed. And the average physician is not going to take the time to do it because it impairs his income and his ability to support his family. So, I don't know. It's, of course, I guess if it's really, really, really traumatic, they might do it.
Exactly, and it's a great point. I mean, getting help, and it doesn't have to be formal psychotherapy, but if someone really needs it, getting help and getting the right kind of help can be done pretty effectively, pretty quickly. And I would argue that ultimately you've got more longevity versus if you have a condition that's untreated, like untreated PTSD, that's going to affect you more long term if it's not treated.
Do you ever see them pushed into it by friends, like alcoholics or?
Yes, I do. And that's one of the reasons why we tried to create a peer support mechanism as well, because we find that, you know, again, someone saying, go talk to Dr. Warren, that's not always what they want to do. But if they go say, well, you talk to one of your peers. But yes, and I'm not for that. I don't think we should put, because you can't make someone do psychotherapy. You can't make someone get treatment for any of this. But I think you have to offer people the variety of things to help them cope, whether it's formal therapy or taking time off or starting an exercise program or whatever. You know, there's lots of different things. We just want to offer that, if that helps. And yes, sir.
You mentioned resilience several times. Can you measure it
Yes.
well, and can you teach it?
Such a great question. So, yes, two things. Resilience can be considered one, the absence of psychological distress, depression, anxiety, what have you. But it can also be objectively measured. In all of our work on resilience, we use the Connor-Davidson Resilience Scale. There's actually a scale, there's several scales. But yes, so you can objectively measure it. You can look at it as the absence of distress subjectively. And my personal theory, and based on our research work with patients, families, and physicians, I think that people inherently tend to be either more resilient or not. But I think the goal is we identify people who are less resilient and kind of help them build their coping skills. Because if you look at, and I'll go fast and I've got to wrap up. If you look at the research after trauma, remember we said 90% of the United States population has a trauma, but only 7.8% of the people have PTSD. So most people are inherently resilient. I think our goal is to find people who aren't, and we help them with that. That's a great question.
Dr. Warren, you can talk all night. Don't
Well,
think you're rushed.
you guys may want to go home. So, it's a great question. Any other questions or thoughts or?
I can recall the old days, when it was about 4 to 6, and those that were off, you'd finish sign-out rounds, and the chief resident used to look up and say, okay, team, those that are off are off, and those that are on, you can call me anytime you want, day or night. But remember, if you call me at home, it's a sign of weakness. Mm-hmm. In the old days, if you showed any signs of all this, burnout or this sort of thing, was a sign of weakness. Mm-hmm. Let me ask you a question. You have a pet program. Do you have a mentoring program? Do you assign every intern to a faculty member and a fifth-year resident? A lot of programs have that.
Yeah.
That's part of their program.
Right. So obviously the general surgery program at BUMC, they have the chief resident and they're working on that. The surgery programs and all the residency programs at BUMC, they require now, because of GME, they require training on resilience, information about resilience, training on stress and things like that. Even at Texas A&M Medical School, where we get our students from, many of our students, they have actually a peer mentoring program they're developing through Texas A&M Medical School, where they have 2 students kind of take on that lead to help create peer mentoring experiences for the medical students. So, yes.
Last question. What is your success rate? You have 25% of the physicians in your organization are described as stressed out, burned out. Of all the people that come to you, how many do you cure?
100%. No, I don't know. I think it's more, I would say the people that reach out, I think by reaching out, that's the success. And then how they deal with it, I'd like to think that what we do between individual therapy or the peer mentoring program, it definitely, I can tell you a quick story. We had a physician who, within Health Texas, who was basically just on the verge of saying, quit, I'm just done, I don't want to do any of this anymore. And they were hooked up with a peer. And after those peer conversations, they totally were able to deal with the problem, and that person stayed in the practice. Because if you look at the cost of losing a physician to a practice or to a hospital system, the financial cost is really high. So it behooves the organization to support people so they don't leave, because the cost of someone leaving. But yes, we don't have rates on our success rate. A lot of these programs we're implementing as we're going. So yeah, I think we're just kind of scratching the surface of the problem. But we want to be something we're talking about as a culture. Yes.
One more question. Do you do any counseling for the police department, you say?
Yes.
If you've sent a policeman to you that shot somebody and you counsel them, how do you decide whether they're okay to go back to the service?
So this is a great question, and it kind of gets to your other question about kind of fitness for practice. The reason the police came to us, to our trauma center, to work with us is because the police psychologists at the police department do that part. Mm-hmm.
Oh,
but what they would find is the police didn't want to go see those psychologists because they work for the police department. So what we try to offer as part of our trauma program is that the police can come to us and we're not connected with the police department. So it's very similar to the issue you brought up as well about if you have an impaired physician, because that gets into a whole different level. Because then you get into reporting issues and things like that. So everything we're doing on the physician level is not on the reporting side. We don't get involved with that piece. It's truly to prevent people from getting to that point. But it's a great question, yeah, I'm not involved with that. We're just involved in helping get them better. Any other thoughts, questions? All right, well, thank you guys so much. I
Anne
really
Marie, thank you very much for
You're
coming to speak
welcome.
with us. We enjoyed it. After tonight, if you haven't seen the movie Sully, go out and see the movie Sully. It's really good. The way he deals with the NTSB, Tom, you're right. The big trauma was at the investigation afterwards. It was really good. Thank you so much.
Thank you. That's okay.
Wonderful. You guys had to get out, get back to Dallas. Anything else? Need some water?
You're so welcome. Thank you for inviting me.
Thank you very much.